We'll go ahead and get started. Welcome everybody to the webinar on We Are Hoarders of Technology. Hopefully this will be a good education for everybody and can learn a little bit about a different perspective around applications, your portfolio, and how that integrates within operations of your healthcare institution. So we'll go ahead and get started. Just a brief. My name's Jason Ewing, and I've been in healthcare for over 20 years in lots of various CIO roles and health system roles. I live out here in the state of Idaho, and these are all the fun things and fun people that are in my life. So want to go ahead and get started. Want to level set here with everybody on what the role of an application is in an organization. What is application portfolio management? Why is it important? And a view into an actual application portfolio and some of the key findings that we'll see inside of there. And you'll actually see some live examples. And then we'll understand kind of the roadmap and how to govern kind of going forward. So I want to start out first with understanding kind of the complexity most of us are aware of, but it does play a critical role in what's kind of going on there. Health systems right now have become very complex through a lot of acquisitions and inheriting a lot of systems through those acquisitions. Many of those are not well communicated to IT or even really kind of considered much of the impacts that they have. A lot of organizations are going to a single EMR. This is creating a lot of organizational change, or what I call less flexibility. When organizations have had autonomous EMR systems, they are able to kind of do and customize their own processes in the way that they want to do things. The challenge going forward is a single EMR is forcing everybody to have to work together, and it's breaking down silos. In fact, it's bringing to light some of the silos that do exist that people didn't really, I guess, realize. In addition, it forces a lot of communication and collaboration across departments or service lines that typically haven't been there before. A lot of this is creating a lot of change, and a lot of people aren't sure how to navigate and work through that. In addition, with the advancements of technology, and it will continue going forward, it's replacing old work, and it's also creating new work. I'll give you an example of that is transcription services. Those are starting to go to the wayside and have been for several years now, being replaced by voice recognition systems. Technology, now that there are more and more EMRs out there, especially integrated ones, it's creating new work for people to be able to gain better insights into their data, their information, their processes that they hadn't been able to attain before. And the reason being is because, you know, you look at the stuff that was on paper, you can't really extract that off of there like you can in today with a lot of discrete fields. Finally, or in addition here, number 4 is the competing with itself. Organizations right now are moving towards value-based care models. They see the reimbursement model is going to be changing. They're creating partnerships with employers, creating new sorts of relationships with insurance and payers. And what that means is that the focus shifts towards producing better outcomes and value at a lower cost, where in today's fee-for-service model, we end up in a situation where volume, and the more volume you do, the more revenue you generate. So it's bricks and mortars become revenue generating centers today, but in the future, in a value-based care, they're expense departments. So whole other topic, but that's creating a lot of complexity today as well. And then finally, consumer demands. Consumers are expecting to have a whole lot more available to them and get services through non-traditional ways, whether that's through telemedicine or through remote visits, however they view that. So what I'd like to talk through is what I call in terms the role of an application within an organization in all this complexity. So the first thing is that people understand what a capability is. And this is in healthcare in general. And here's just some examples of that around population health management. How do we manage our vendors? How do we do care management? Those types of things. What supports those capabilities are processes. And these are examples here of what is the patient assessment process. How do we transport a patient within the hospital or from their homes to a medical facility? So and these capabilities can be supported by one or more processes as you go through. This is where the applications come into play. So these applications that are across the organizations do two things. One, they support business processes, and they help automate those processes or drive efficiencies in those processes. The second thing it does is it collects the data, whatever input and content that's been put in into those systems. And then finally, the infrastructure. This is the layer that supports the applications, which support the processes and then the capabilities. What we're going to focus on here is these applications. If these applications support the processes and help automate and break down those operational silos, then the application portfolio is one of the most critical pieces in any organization to understand what its opportunities are or how to approach and take on standardizations. Most organizations, like I said, they understand the capabilities. Many of them jump down and start looking to IT to solve a lot of process or efficiency problems when they skip the components of what the processes are. And the reason they do this is twofold. One is that we are in a healthcare industry where it is a very human-to-human, people-centric environment. And so therefore, sometimes it's difficult, especially when mergers and acquisitions have occurred, that these conversations are new, or they're not sure where they start, and the processes start and end, and where the handoffs. Typically, they're never documented. So therefore, they look to the application and the application vendors to drive those changes in new standards. Well, what ends up happening many times is that you end up with the same set of processes, just a new coat of paint on the old system, into a new one. And that makes it very discouraging and difficult, because when changes need to occur operationally on their processes to make improvements, because they're not collaborating, it makes it difficult in the background for IT to configure the system to be effective and efficient, because there's a lack of clarity in who the decision makers are on the processes. So this model is the foundation for what we're going to go through here today. So here's what I call the case for change, and this is that we have a lot of fragmented and misunderstood application stewardship. We don't know who owns what in an organization. It's not clear on the operational side who does. Sometimes it does, but not on all of the systems across the board. We also have duplicative technology solutions with the same common capabilities. And we'll see that example here in a minute. We also inherit an enormous amount of systems through acquisitions, and it's unclear of what to do with those, once you inherit them, because you just added an additional expense, as well as duplicating people's processes without deploying standardized systems across the board. We also have unclear ownership of the applications across the system. We may have a radiology department that owns maybe a particular PAC system and another radiology area in a clinic that may own their own. And so it makes it difficult to say what is our standards around that because it isn't clear. And then we have what a term is siloed operational processes for similar business functions or similar patient care practices as a result of redundant systems. So a patient that enters any place within a health system would receive a different experience than in another place within the health system. Many of that's driven because of the redundancies and the duplication of the systems. And then finally, all of this stuff creates a lot of IT confusion on priorities, the demand as a result of these redundant or underused systems. So it makes it very challenging for IT and creates a lot of stress and unnecessary work because there's a lot of fragmentation that's going on out there. So what I wanted to do is go through a case study of the work that was done. It was done on a $3 billion health system, rapid acquisition growth. There were 2 separate divisions within this organization, a total of 9 hospitals and approximately 15,000 employees. So this case study was presented to the executives at that organization. And the question was asked to them, how many applications does the organization own? And many of the executive leaders weren't sure, nor had IT ever produced it, but they were in the A and B range. And in fact, they were up to 1,321 applications. So they were quite surprised and stunned by the fact of how large their portfolio was. This is an example of their application portfolio in the acute care and diagnostic services. You have to take out this is the count of applications by service line. You have to take this IT one out because that deals a lot with Microsoft Office, Adobe, those types of things that are kind of the desktop publishing. Not that there is an opportunity there, but from the point of this presentation, we wanted to focus a lot more on the operational impacts. So if you look over here, there were 27 systems for pharmacy. Now, if you just think about that model, that the applications support the processes, imagine the variation and the different ways in which all of those pharmacy departments were operating and functioning. Were there patient safety problems and concerns because there were so many different ways in which it was being done? Were there gaps in best practices that could be adhered to? What do we do with all of the data that is sitting in those systems if everyone moves to a single system? Because they still have to sit out there. And I'll talk about that in a minute later. Over here, you can see radiology had 34 imaging systems. So imagine being a patient that enters the health system in maybe a rural facility, and they have their a chest CT scan done, and then they have to be transported to a larger tertiary center. And then all of a sudden, because they don't have access to all of those images, they have to retake the images again. And once again, costing the patient and insurance more money just because there's no continuity between and across the health system. So this becomes very, very large problems for organizations. Now I'm going to talk about rehab here in just a minute. So on the ambulatory and revenue cycle sides, the way this is grouped, you can see here they had 38 electronic medical record systems. So the practices of care were all over the board. In addition to that is the data in all of those systems were not tied together. There was no integration. There was no enterprise master patient index to connect all of those. So we look at this as a potential patient safety problem because the physician doesn't have all the information, or it's being faxed and stored in paper somewhere. So HIM had 38 systems. Now, this is the area I feel really bad for, is because in HIM, they're the ones that have to do not only the coding and the management of the medical record, but they also have to do a lot of release of information. So they've got to have access to all of those EMRs out there to be able to go ahead and pull all of a patient's records, and then make sure it's even tied together appropriately and matched up, all done by humans that are trying to match birth dates, addresses, social security numbers if they exist, and whatnot, creating an enormous amount of time and pressure on your ROI departments. So there's a lot of downstream effects because of those things. Over here is the 41, and then on the prior slide there was quite a few in the rehab. I had taken a moment here and paused with the executive leadership, and I said, you just acquired an inpatient and outpatient rehab hospital, and the question for them was, how many applications do you think that you inherited? And the CMO, it said, 20, and the COO said, we probably got 25 of them. And I said, no, you actually inherited over 200 of them, versus deploying your standard enterprise systems, of which there was really no declaration of anyways. So it was an enormous amount of expense that they inherited, but also IT was in a bad position because they took those systems on and had to figure out how they worked and how to handle changes and support service requests and incidents to all of those additional things. So, and on the business services side, you can see what that portfolio looked like. Finance was just as bad in a situation with the number of applications that they had. What's interesting over here is that building services, none of their HVAC systems, which are all usually tied to technology, were on different versions and different flavors to try to manage all of the HVAC systems across all hospitals and clinics. So it became very challenging and burdensome to even the billing services groups. So I wanted to share a couple of just small but interesting findings that through the application portfolio that was really fun to discuss and understand. And one of them was, if you haven't heard of Razor's Edge before, but it is a foundation system for most health systems foundations to manage their donors. Send templated letters out to them, those types of things. And Razor's Edge is built to be able to handle multiple foundations and share the same type of templates and letters that go out, management of the kind of a CRM type of solution. In this organization, they had 6 foundations. 5 of them were all on their own instance of Razor's Edge. It means there were 5 different servers running 5 different versions, having 5 different configurations and 5 different types of templates and ways of managing things. So what this meant was that the organization, when it came to upgrading, it had to have resources in IT to have to do those upgrades 5 different times. In addition to that, it made it difficult for them because everyone was configured differently. So it was even more of a burden on IT to try to document and manage multiple configurations. Now, that's just a simple example when we talk about application duplication. The next one I was actually pretty impressed with, but still had some disjointedness in it. They used the product called Halogen for performance management. And in Halogen, as I said, this organization had 2 regions. In the West region, they did their performance reviews annually based on the employee's anniversary date. In the East region, they did their annual reviews annually. So regardless of when you were hired, you had an annual review at the same time. So because they had one software application, they still couldn't come to agreements on how they wanted to operate with their performance management. And this created some problems. And in the executive meeting, I said, here's the impact, is you've got 2 full-time employees, not in IT, tweaking the Halogen system to be able to function and work because we can't agree on when we do annual reviews. So this, once again, is another example of how do we work as a health system, and how is our processes still siloed and independent, causing some inefficiencies and effectiveness of using the technology and standardizing across the organization. I hope you find that that's pretty interesting, and you may find that in your own organization you have some of that stuff going on. So this organization was migrating to Epic, and they had a phase 1. These on the left-hand side are the applications that got replaced by Epic, and you'll see like Medical Manager, they had 3 instances of that, 2 instances of NextGen. All of these systems were being migrated over. Now, what the organization didn't realize was that those systems still stayed out there even though you migrated over. And it was an interesting comment that the CMO said. He says, well, Jason, why don't you just go shut those things off? And I says, well, I could go into the data center and just hit the power button and we could just shut them down. I says, the problem is that is your data. And I said, what do you want to do with the data that's in there? Because you have to maintain that data per your retention policies within your organization, of which maybe they didn't have those retention policies well documented out. But I said, well, what do you want to do with the data? So that brought about a whole new look, because many times it's IT, what are you going to do with the data? Well, IT doesn't need the data to run IT. The organization and compliance needs the data to run the organization. So it began to shift some accountability and responsibility back over to the organization to help figure out what it is that they wanted to do with that. And it surfaced a whole new set of problems. We're going to talk here in a minute about cost, because what I've shown you earlier is mostly count as it relates to process impact. The second phase was really looking at the ambulatory and the rest of the ambulatory and inpatient environments. And this was the add-on to additional systems that they needed to get rid of. So in combination there was a total of about 159 software applications that became legacy and no longer needed to be used. And I'll tell you what that dollar amount equaled out to a little bit later, because it was quite enormous. So the way in which we began to look at is you have to slice the information up in a way that helps you better understand these systems. And so what we did is took those legacy systems and we set into 5 buckets. Which one of those systems contained clinical data, which contained ERP data, which contained scheduling, documents, and patient financials. And you'll see in here that there are, in the clinical data, there's centricity, but over here in document management, you still have centricity. And over here in scheduling, you have centricity. So the application can be duplicated multiple times based on what type of data resides there. The reason you do this is to help better understand and align what type of archive and where this data is going to go when you do actually start to shut those systems down to gain some monetary money back, but also continuing to preserve the information. So once again, application supports and automates processes and also has to deal with the data side of it. And this is kind of a model and picture of how to start to chip away at that so that you can begin to architect the right type of technology in the background. So onto the cost side of it. I asked the organization how much money were they going to spend on the application maintenance as a whole. Once again, they articulated that they think it was A or B, 15 to 20 million is what they spent on their application portfolio. Not the 159 systems, but everything. The actual answer was that A was 2011, B was 2012, all the way on up to 2015. This 2016 was the projected. So you can see that not only was the count very high and processes disjointed, but you also had an appetite of technology that doubled in 5 years. Projected out another 5 years, by 2020, they would be at $60 million if they keep on the trajectory that they're going and do nothing with those legacy systems. You'll notice here that they had a $6 million jump. This is where the majority of their acquisitions occurred. And that's where the bulk of the financial weight. And a lot of times you can start to tie this to the concerns of why IT is getting so expensive. Well, IT is getting expensive because the departments and acquisitions and their appetite for what they want is so great. And that's where you start getting into, well, how are these things being governed? And that's a whole other topic and piece that we'll be covering in another webinar. But meanwhile, you can kind of see the struggle and the change. So the question brought out to him is, how do we turn the corner and start to reduce this cost? What is that plan to start to drive that down? Now, the difference between this number and this number were the 159 systems, which totaled out to about $9.2 million in maintenance, the systems that are just sitting out there running. That didn't include when systems became end of life and they had to be upgraded, or the hardware that had to be upgraded, and that capital expense that was required for that. So big challenge ahead of them, a lot of money just sitting on the table because of their acquisitions and migrations to a single EMR environment. This is what I would call the application portfolio timeline. You can replace these dates with current dates today, but there is a component here of actually gathering your portfolio, getting that inventory and getting it correct, tying the actual costs out, starting to put in application portfolio governance, which allows the departments to begin to manage their portfolio across the board. And then you actually go through a short-term and long-term rationalization effort. But meanwhile, you have to begin a life cycle management of this process with governance so that you don't end up in another situation where you've got another bulk of systems that have to be decommissioned and become an expensive mess for yourself. This is the blue line down at the bottom is more your long-term sustainable methods that you build in along the way. So this becomes a true life cycle plan, but it's in partnership with operations. I've always articulated out to folks is that 99% of the systems that IT supports are not systems that IT needs to use to run IT. They're everybody else's stuff. So when the conversations come up and we start asking, well, why is IT so expensive? The conversation shifts quickly over to, why is your pharmacy so expensive? Why is your radiology department so expensive? The challenges have been in the past is that IT has always seen this and kind of had the gut feeling about it all, but has never really produced the information and the visibility to the organization like they should. And that's where a lot of contention and problems between organizations and IT a lot of times exists. It's just the transparency on the information, and then having the organization help manage appropriately. So I won't go into governance, but these are some things that you would want to govern. There's a lot of pieces and parts to this, but I like to see organizations start with their application domains and begin to govern that with the operations, as well as their strategy and roadmaps. And then you start to slowly, as you mature, add in additional components and pieces to this so that you can be a little more effective in maturing your governance and the overall management of IT. This is what I call the capability of an application portfolio management. Obviously governance at the top, but there's application rationalization that occurs. What systems are we going to get rid of? Which systems are we going to keep? Which ones are going to be declared as standard across the board? So when new departments or new organizations come in, they get deployed the appropriate standardized systems. Application lifecycle, the upgrades get managed, and that becomes visible on roadmaps. You begin to manage the cost. You start looking at standards. You start looking at the risk of the application. It's reaching end of life. We're going to be running out of support. What risk does that have and impact to the organization? And then, are we getting the value out of the system that we should be? When you look at the Razor's Edge instance, there probably wasn't a lot of value out of having all 5 instances versus 1 instance, plus being able to share best practices across the board. But those are opportunities for governance to look at those and make some decisions around it. Left side is all the people, the processes, and the tools to help through this process. And on the right side is the actual governance and the integration of the portfolios between project management and application portfolio management. So with that, that concludes. I hope that this was helpful for folks, and gain some sort of insight for your own organizations. I think we'll go ahead and conclude. If you got any questions, you can feel free to email myself here, this email address. We'll be doing another webinar, which will be on December 18th, and instituting effective governance. No cost to that, it's just free, but it allows you to get some insights into some real world ways of implementing governance and ways to look at it a little bit differently so that this relationship between IT and operations becomes more effective. So with that, we'll go ahead and close out. Thanks for joining.